So this is my disclosure slide. So I will be talking about severe familial hypercholesterolemia. So we know all about what is familial hypercholesterolemia. So it is a genetic disorders. It is a mutation mainly in the LDL receptor gene, but it can be also in other rare genes like ApoB, PCSK9, LDL RAP gene. We know that it causes severe accumulation of plasma LDL cholesterol, and if not treated early, it can lead to very severe atherosclerotic cardiovascular disease. So when we talk about severe hypercholesterolemia, and this is really what touched the familial hypercholesterolemia, we ask ourselves, do we need risk stratification? We know these patients are already having a high blood cholesterol, high risk for atherosclerotic cardiovascular. So why we need to risk stratify them? First of all, we know that although maybe on the short term, their risk for cardiovascular disease is not high, but on the long term, it's high. This is why we need sometimes using this, the regular cardiovascular risk score like Framingham or other risk scores may not put these patients in the real risk category. The other thing, we know that there is a lot of heterogeneity in the risk, and this is really depend on the LDL cholesterol levels, on the presence of other risk factors, again, like diabetes, hypertension, smoking, obesity, family history, the presence of already subclinical atherosclerotic cardiovascular disease, like a high aortic calcium score or aortic coronary calcification. And also we know that newer treatments, like my previous colleague had, touch on them, like PCSK9 inhibitor, lomitibide, ibnocumab, apheresis, and more are coming, are really relatively more expensive compared to statin and ezetimibe. And this medication may be really needed to treat these patients. So we need to know which patient should go for this advanced treatment, and without really risk stratifying these patients, even if they are already at considered at high risk, should be appropriate. So we know that higher LDL cholesterol mean greater risk. So if we look at this diagram, so on the y-axis, this is the cumulative LDL cholesterol, and on the x-axis, this is age in years. So we know that patients with severe homozygous familial hypercholesterolemia, if they have two nil allele, they usually develop coronary heart disease by age of 12. And this is why we need to screen this patient earlier. And this is all, again, related to the severe high level of LDL cholesterol early during their lifetime. On the other hand, patients with heterozygous familial hypercholesterolemia depend again on how severe this heterozygous, how severe this mutation. So those with less severe mutation can develop, atherosclerotic cardiovascular disease usually after the age of 40, but those with severe, even they can develop before the age of 30. So again, we need to know which category of mutation these patients fill in, again, to optimize their medical therapy. So from this study, we know that the presence of FH mutation will increase the risk of coronary artery disease. So you can see clearly here, these are all patients with familial hypercholesterolemia, but some of them with positive mutation and some of them with no mutation. So if you can see those with no identified mutation, the risk for CAD is still present and depend on the level of LDL cholesterol. But those patients who have the mutation, their risk for CAD is even aggravated when the LDL cholesterol is high, and in the presence of this mutation. So it's very clearly to identify those patients who have this mutation and high LDL cholesterol, so we can treat them more aggressively early in life. The other thing is also to notice that there is a lot of overlap between the LDL cholesterol level. You see it here in the x-axis between patients who are normal, heterozygous familial hypercholesterolemia, and homozygous familial hypercholesterolemia. So some of patients who have heterozygous, but they have severe mutation, they can present with an LDL cholesterol similar to those in patients with homozygous familial hypercholesterolemia. And the opposite is right. Some patients with homozygous familial hypercholesterolemia who have two mutations but less severe, they can present with LDL cholesterol, in the less levels, which is, maybe look like heterozygous FH. So this is where, genetic mutation help in this patient. So I don't want to confuse you with these slides, but again, just to tell you that how complicated even the phenotypes and the genotypes in familial hypercholesterolemia. So if we look at the phenotypes, mean those with high LDL cholesterol, usually patients who have the LDL null mutation, mean no activity at all of the LDL receptors. These are the patients who are homozygous, and this is the most severe form. Those patients who have compound heterozygous with LDL receptor null, also they can represent patients with homozygous. So this is why, again, we have to keep in mind, not all patients with heterozygous considered less severe. Sometimes they present as a very severe homozygous phenotypes. So the other thing we should also know that familial hypercholesterolemia patients are like other patients that we usually see them in the clinic. So they are exposed to these common risk factors, again, like, obesity, smoking, hypertension, diabetes, and so on. So you can see clearly from this table that, patients with familial hypercholesterolemia, they are already at high risk for cardiovascular disease. And on the top of these risk factors, the risk for the odds ratio for developing cardiovascular disease is higher. Especially look here at patients who have hypertension and diabetes, almost like 8 to 6 fold increase. And this is even when we correct for this risk factor, still the LDL cholesterol level is considered as, a major risk factor in this patient. How about the presence of cutaneous stigmata, especially the corneal arches and the tendon xanthomas? Again, it has been shown, again, by the different study, these patients who have these cutaneous xanthelasma or corneal arches, their risk for developing cardiovascular disease is higher. Again, maybe indirectly affecting the level of LDL cholesterol and the burden of LDL cholesterol in these patients. How about the presence of lipoprotein little a? One of the other genetic predisposition that we will talk about it later. So those patients with familial hypercholesterolemia, if they have also a higher LDL cholesterol, which is more than 50 milligram per deciliter, so you can see clearly the risk for developing, again, a myocardial infarction is higher than those patients with FH, but LPA is relatively normal. So again, indicating the need also to look at other risk factors in this patient. Secondary versus primary prevention in patients with familial hypercholesterolemia. Again, those with secondary prevention, they are again at higher risk of developing a second or third or fourth event. So if they have a background of familial hypercholesterolemia. This is why we need more aggressive treatment to be started earlier in these patients, really to stop the burden of cholesterol deposition and the atherosclerotic burden. How about subclinical coronary atherosclerosis? We know with the coronary calcium score, this patient, they have either aortic calcification or coronary calcification, and the higher the calcium score, like more than 100 in this patient, indicate even in primary prevention that these patients are at really very high risk. As you can see from this the ROC curve, that those patients who have a very high calcium score, then their risk for plaque deposition and plaques also instability is high in this patient. With the International Atherosclerosis Society, we tried to come with a definitive for how to define those patients with severe familial hypercholesterolemia. Again, why we need that? This is why we said, not all the familial hypercholesterolemia, they behave similarly. So some of them, they may be stable on, maximum dose of statin and ezetimibe, but some of them, they need more advanced treatment. This is where we need to identify those who are at extreme or high risk. So what we had added to the formula, that those patients who are older than 40 years without treatment, smoking, male gender, high LPA, low HDL cholesterol, hypertension, diabetes, family history, chronic kidney disease, and obesity. So if, let's say, for example, at presentation, untreated LDL cholesterol is more than 10, then you need to reduce the LDL cholesterol by 50%, and the optimal goal is LDL cholesterol below 2.5. But now we can see even from the new guidelines, the LDL cholesterol should be below 1.8. But it is not that really easy without using this advanced treatment to bring this LDL cholesterol to so much low level. It is really very challenging in this patient. This is why we need to start combination therapy early in this patient. Again, those with subclinical atherosclerosis, for example, if calcium score is more than 100, then again, you need to reduce LDL cholesterol by 50%, and the LDL cholesterol should be below 1.8. And if there is a presence of atherosclerotic cardiovascular disease, then we may also need to bring the LDL cholesterol even more lower. And in the new guidelines, we see a level of even below 1.5 in this patient should be optimal. How about treatment? So with the advanced treatment, like the PCSK9 injection, we saw clearly with the Rutherford and the Odyssey FH1 and FH2 that now in these patients who are resistant for treatment, we could really lower the LDL cholesterol below the guideline target levels, which is below 70 milligram per deciliter or below 1.8 millimole per liter, using this advanced treatment, whether evolocumab or alirocumab every 2 weeks in this patient. And also, in addition, those patients who are severe hypercholesterolemia or homozygous familial hypercholesterolemia, but they do have some residual activity of LDL receptor, usually also they can respond to this PCSK9 injection. And this is well highlighted by the evolocumab study in the TUSAID study, that those patients who still have some receptor activity, they can reduce the LDL cholesterol up to 25%. So again, we could also try it in patients with homozygous familial hypercholesterolemia. Evolocumab, which is an ANGPTL3 monoclonal inhibitor. ANGPTL3 activate lipoprotein lipase that convert VLDL into LDL. So if we prevent this conversion, then we reduce the number of LDL particles. and also we improve the expression of the LDL receptor. Ivnocumab is an FDA approved to be used in patients with, again, severe hypercholesteremia or homozygous familial hypercholesteremia, and on the top of other treatment, it can also reduce the LDL cholesterol almost by 50%. How about inclisiran, which is an siRNA interference? Again, it had been studied in patients with familial hypercholesteremia, and it showed also an excellent, and this is a 2 injection per year, which make the compliance of this patient is better. Lomitibide, again, approved for patients with homozygous familial hypercholesteremia or compound heterozygous. It acts on a component called mitochondrial transfer protein to inhibit the VLDL formation or the chylomicron formation, and hence decrease the LDL cholesterol and LDL particles in the blood, and also increase the expression of the LDL receptor. Also, it had been tried, it reduced the LDL cholesterol significantly in these resistance patients, almost by 50%, and it had really a good safety profile if these patients are really compliant on low fat diet. LDL apheresis is another option for this patient, although it is an invasive, although it is needed every 1 week or every 2 weeks, but it really can reduce the LDL cholesterol acutely up to 80%. This is why these patients need to come for treatment. And the other advantage, it also can reduce the lipoprotein A, which so far most of the treatment in either phase 2 or phase 3. So it is the most, appropriate treatment if this patient also, in addition of familial hypercholesteremia, have a high LPA. So to summarize here, this is a good algorithm for those how to treat these patients with severe familial hypercholesteremia. Always you need to start with high intensity statin plus ezetimibe as a combination therapy. So if the LDL cholesterol is still not ideal or not below 50% reduction, then you can consider triple therapy with PCSK9. And in addition, also you can always think about adding also lomitibide or ivnocumab or LDL apheresis. Liver transplantation has been tried, especially in severe, I think it doesn't have any more rules now, especially with this advanced treatment. So in conclusion, we know that elevated lifetime risk of cardiovascular disease is very well established in these patients with severe familial hypercholesteremia, but we know that there's a lot of heterogeneity among familial hypercholesteremia in terms of risk, and this depends on the LDL cholesterol levels, the presence of other risk factors, the presence of subclinical atherosclerotic diseases, and also the presence of previous cardiovascular disease. It is very important to identify these patients in order to have the best optimal treatment for them, which is also considered as cost effectiveness. With this, I will stop here and thank you very much.